Well, thank you very much for coming to hear Professor Rosemary Polomano's talk that depicts several epochs or eras in her own research life. We're very proud today that our little program is being graced by Rosemary's presence. And just to give you a sense of Rosemary, I have personally known her for some time, since she was at Penn State, working with cancer pain and adapting an outcomes instrument that we began here at Tufts. She continued to use that, but her career evolved in a very important way in response to another new demand that arose about a decade ago, coming on to a decade ago, in the context of military conflict. As we all know, there were many injured warfighters and civilians, and their pain control needs were very significant. In today's battlefield, there are many instances of limb injury and phantom limb. There are many penetrating wounds, traumatic brain injuries, just a whole set of extremely complex problems that are admixed with other problems like PTSD. So Rosemary rose to the challenge and has addressed many of these issues, and we'll be talking on a number of items without trying to steal her thunder, and mindful that she has a lot to say in a short time period. I should also point out that little known things about Rosemary are that she had a very distinguished early career in rat studies and developed a paclitaxel model of chemotherapy-induced neuropathy that she showed me is still being cited in 2014 in current work on chemotherapy-induced neuropathic pain. I could speak for a long time about all her accomplishments, and actually, as it happens next week, I'll have a chance to do more of that because she's going to be honored as a distinguished nurse, clinician, researcher, and educator. I may be garbling the things, but it's a very honorable award at the University of Pennsylvania, where she has been for a number of years. So without further ado, I'll introduce Rosemary to the podium and thank her again.
Thanks. Thank you, Dan. Thank you, and I think we've all benefited from Dr. Carr's generous mentoring and being a generous scholar, and I too have had the pleasure to benefit from his mentoring. Okay, I have a lot of slides and a lot of pictures to go through, but I thought I would first start really talking about my early career and as a clinician doing research. But one of the things that I did that was really influential was to actually study a cancer pain model for patients with sickle cell disease-related pain. And my colleague, the late Daniel Brookoff, who was an emergency medicine physician at Penn, and I got together, and in 1988, we developed a protocol for our patients with sickle cell disease-related pain to keep them out of the emergency room. We had high numbers of emergency department visits. We had many patients on imipyridine, which was not safe. And we also had patients being readmitted to the hospital. So we changed the paradigm of treating sickle cell disease-related pain by treating it like cancer. And quite frankly, we were not very well accepted in the pain community about doing this strategy for patients with chronic non-cancer pain. So the results of our study in a cohort of 50 patients that we transitioned to an outpatient protocol with controlled release morphine and monitoring them for chronic pain. We actually reduced pain intensity by 44%, inpatient days by 57%, length of hospitalization by 23%, and number of emergency department visits by 67%. We actually made world news, and never did I think with an observational, exploratory, or descriptive study that we'd get published in the Annals of Internal Medicine, a very influential journal. But we did, and we quickly found ourselves traveling all over the country to help emergency departments set up this kind of protocol. Now, I did go for my doctorate, so there's a big gap, but was still productive in many ways, both clinically and with research. But I wanted to actually talk a little bit about my paclitaxel rat model research right now. And so in 1996, I was keeping my promise to a patient, and I think that as a researcher, your practice informs your research and your patients inform your research. And I was always really passionate about my patients really giving me leads on what I should study. When I was doing my dissertation research, I had a patient who was not eligible for my study, but wanted to desperately be on it. And she said to me, if you could just get rid of my burning hands and feet, I could die comfortably. And I spent a lot of time with this woman because I had downtime in the clinic while I was collecting data for my dissertation. So I got to really know her. And she had lung cancer, and she was getting paclitaxel, and she really wanted me to study this. She was telling me, you're studying the wrong pain. You have to study this pain. And so my colleague, Dr. John Farah, who was a great grantsman, got a group of us together to get ideas together for an NIH grant. And my colleague, one of our other colleagues who's being mentored, Andrew Manis, an anesthesiologist, we were in our group, and I proposed my research plan to study chemotherapy-induced peripheral neuropathy from paclitaxel. And Drew, if you have to know him, he's now the chief of anesthesia at the NIH, turned around and looked at me and said, Rosemary, you can't do that study in humans. You're going to have to study rats. And I thought to myself, are you crazy? I know nothing about laboratory research. And he said, go to Hahnemann University, because Dr. Gary Bennett, who was the director of neuropathic pain then and internationally renowned for rat model pain research, just came to Philadelphia. So I went to see Dr. Gary Bennett, made an appointment with him. And what my message to him is that I have no funding, I have no laboratory experience, I never took Biology 101, and I am severely rodent phobic. Can I please work in your lab? And his message to me was, because I was a nurse, yes. And he put me in the very capable hands of Urena Clark, who actually went to Northwestern University to get her PhD in neuroscience. And she trained me in animal research. As a first order of business, I had to get funding. I had no funding. And so these were the small funding sources that paid for drug, paid for a little of my time, and I got a postdoc fellowship. So I was within 3 years of getting my PhD, so I was able to do and eligible for a postdoc fellowship. So in 1998, I did get that, which gave me time to do this research. But the second order of business was to construct a rat model that mimicked the human case. Now, who am I to critique the internationally renowned neuroscientist studies on chemotherapy-induced peripheral neuropathy? But to the best of my knowledge, in reading these studies, I was thinking, these rats are not behaving at all like humans. They're falling off the rotor rod, which is a test for motor. Taxol is a sensory neuropathy. They were having severe numbness. We would have stopped therapy at that point in a human before they would have gotten that toxic. So they obviously weren't collaborating with clinicians. So I went to Gary and I told him, and he said, we are going to find the right model that mimics the human case. And so we actually developed this dosing schedule and got it right. So you'll see with subsequent studies. We actually developed a low dose, a medium dose, and a high dose schedule. And we were just lucky that our high dose was the top threshold for producing the kind of neurotoxicity that we see in humans. And I'll show you how we prove that in just a minute. So I went on to being a laboratory researcher and working with rats, and it was really wonderful because there was no informed consent. All my subjects showed up on time, and they dropped out of my study when I said they could. So looking at the tests for actual pain that I did, we tested these rats for cold sensitivity. We tested them for mechanoallodynia, which is sensitivity to touch with these von Frey hairs. So if any of you do animal research, they get applied to the plantar surface and you bend them and you take the number of grams that evoked a paw withdrawal. So the more sensitive the rat, we do this in humans. Von Frey is used in patients with diabetic neuropathy. The grams that evoke the paw withdrawal is the number of grams that is assigned to that rat. And the lower number of grams that evoke a withdrawal would be a rat that would have sensitivity to touch. And we also tested them for heat sensitivity, hyperalgesia, and pain from heat. And they were placed in the Hargraves testing box. A light source was placed onto their plantar surface. And when we measured their time to withdraw. And those rats that were sensitive and neurotoxic from the Taxol would actually withdraw their paws early. And so this is me at Neuroscience, 27,000 people at Neuroscience. It was one of the most overwhelming conferences I ever went to, presenting our early rat data on a set of about 20 rats that we were able to demonstrate the kind of neurotoxicity that we wanted. But then in 1998, I went and transitioned to a new position. I was at the University of Pennsylvania. I went to the Penn State College of Medicine and the Hershey Medical Center. And there I got a KO1 NINR award to actually finish my rat research. So that was really helpful. But and I had two mentors. Gary Bennett stayed as my mentor, and I also had a neuroscience mentor. But many of you know that K awards don't really provide a lot of money. And so I really had to do a lot of the work. I did hire a laboratory team on the recommendation of human resources, but I had to fire them very quickly because they were monkeying around in the lab. And I finally got my own lab, and here was my laboratory team. And they are actually performing every single kind of test that I needed to do. Tests for pain, poking in the eye. I did electrophysiologic recordings and I did immunocytochemistry, looking through the microscope of tissue and nerves, and that one up there, a fellow up there is pouring the drug. So this is actually several years of work on all the components, and I don't expect you to read this, but I just wanted to show you two pieces of data. One was our data about the mechanoallodynia, the touch, and you can see that with the rats that actually got 2 milligrams per kilogram total. That was the dosing schedule. That was 0.5 milligrams 4 times every other day. And 4 milligrams, that was 1 milligram every other day times 4. But you can see that both of them are pretty close in terms of evoking touch. And there is a departure from control that's statistically significant at a period of about day 15 is where we started seeing that touch sensitivity. So we were really able to demonstrate with this rat model something very similar than we see in humans. But one of the things that was very daunting was to be able to actually determine that the top dose of my rat model dosing schedule was actually the top dose that we would see that would produce enough toxicity that would be serious, that would mimic the human case where we would stop therapy, but it wouldn't damage nerves where rats were not able to walk. We don't treat people to that toxicity, or that they had so much pain that they were uncomfortable. We don't, again, we would stop therapy in a patient. And so we did electrical recordings of numerous tibial, single nerve recordings of the tibial nerve. And just to, very briefly, we did find that the lower dose, which was my high dose in my model, was the dose that actually produced the sensitivity. And any higher dose than that really produced nerve toxicity that, again, we would not see in the human case. So I was really excited about that. So my rat model is actually used by many researchers across the world in terms of trying to produce a systemic neurotoxicity neuropathic pain model. So these are just some of the publications. This is a review article that we did on painful peripheral neuropathy. This is actually part of our data publication, the rat model data that produces the schedule and the actual toxicity that we were able to evoke in rats. And then I always, along the way, made sure that I interpreted everything for nursing and put information in our nursing journals to get to clinical nurses about my work. So this is an article looking at the significant and undertreated and underrecognized problem of neuropathy in cancer survivors. Now, those of us who are mentored pass it on and mentor other faculty and other students. And I have the pleasure of working with Linda Hatfield, who is a pediatric researcher. When I was at Penn State, I actually had to do research in the Children's Hospital. I had never done research on children. I quickly learned never wake a sleeping child. But Linda got a grant in when she was working for me in 2004. Then I left and went back to Penn. Linda was still there, but Linda's area of research was oral sucrose and with immunization. And she got a very small grant, did a randomized controlled trial. It was really great. We analyzed the data, we wrote it up, and she said, "I want to go for into pediatrics, put it in pediatrics." I said, "Linda, it'll never happen." I said, "That's too high impact. You did a really small study, single institution." She said, "I want to do it." I tried to discourage her. I was a terrible mentor. In any event, I finally supported her. We had a perfect manuscript. We sent it in. It got accepted the first time. They just asked for 2 pieces of information. And this study actually has guided practice where babies get oral sucrose when they get their immunizations in the outpatient area. At the time, in 2006 and 2007, they were just receiving oral sucrose in the ICUs. And Linda and I continue to do systematic reviews and integrative reviews of pediatric pain so that we can advance this information for nurses. But really the highlight of my career, and what could be better as a researcher to have 2 of the most amazing populations of patients, cancer patients and those military populations, are combat injured service members. So I am really blessed to work with them. But my career somehow got sidetracked, and I don't know how it happened, but I kind of think I know how it happened. It was the car effect. And Dan actually brought us all together in 2005, and in Sydney, Australia, Dr. Matt Gallagher, who's renowned in and leader in veterans pain, and Colonel Chester Buckenmeyer, who leads the pain management initiative in the Army. And Dan had identified a request for a proposal for us, and said to us that we should apply for it. And I thought, I'm a researcher. I can help write a grant. I can do the outcome and the measurement piece. I'll just go for it. And so we partnered, and with my colleague John Farah, who you saw before, and we actually got the grant. I think out of 100, 4 were funded and 1 was ours. Now, we worked over Christmas holiday. I had Christmas dinner at my house that year, and my family didn't even get in the door, and I said, "You got to leave at 8:30. I got to write a grant." And so we all gave up our Christmas vacation, but it was a success. Now, what did we write about? Well, in 2003, Colonel Buckenmeyer did the first regional anesthesia catheter on a combat injured soldier, Brian Wilhelm, who you see in a minute. This is when Brian is 24 hours after in the combat support hospital after he has a devastating, I won't show you, limb injury to his leg. He's with his troops, and he actually is then flown to Lonsdale Regional Medical Center and he's given a heads up, still has his leg in a stabilizing device. He's given a heads up that he's getting good pain control. And then he did eventually lose his leg, which happens with these devastating injuries. They can be nursed, but the limb often cannot be salvaged. So Army Specialist Brian Wilhelm was the first to get a regional anesthesia in a combat support hospital. So we wanted to test the effects if early regional anesthesia would actually make a difference 2 years after a combat injury or 2 years after hospitalization for a combat injury. And so we put in this grant. We have a huge study team. It's the RAMPO study. You can see the acronym and what it stands for. We have 381 patients currently. The study's done. We are analyzing data, and we have about 6 or 7 publications to keep us busy over the next year to get out with this study. What we did find, and one of the data sets that I'm working with, we have so much data. We collected about 20 different patient-reported outcomes on these patients over 2 years. But one of the things I'm working on now that's really quite interesting is that we're looking at whether injury severity score, ISS, which is a trauma index score for severity of trauma, we're looking at whether that has any effect, the severity of the injury at the time of injury, any effect on long-term patient-reported outcomes. And it doesn't. So this RAMPO study, the design is a prospective longitudinal study over 24 months from the time patients are actually discharged from Walter Reed or Brooke Army Medical Center in San Antonio. Only those patients with major limb injuries are eligible, and patients are actually interviewed by phone on a variety. Again, it's a multivariable study. These are the demographics on the subset of patients that we were able to get injury severity scores on, 347, and those that were actually contributed more than a couple of data points over those 2 years. You can see the distribution is fairly equivalent with all the injury severity categories. And when we looked at how injury severity affected the multiple outcomes that we collected, well, it didn't. There was no injury severity effect for any of the pain intensity outcomes we collected. We had no effect on pain interference. These are measures or outcomes that are with the brief pain inventory. And general activity, there was just one successive period of time, 12 months to 15 months, where there was a significant change in outcomes. But it didn't matter, which is a very important message that there are silent wounds. So these were the outcomes that said that people who had mild injuries have the same outcomes over the course of 2 years after they leave the hospital as those who had really severe and critical injuries. This is just to show you what the data, the pattern of the data, the distribution of the data look like. So they're fairly similar. And you can see, so, got to start paying attention. We all have to start paying attention to pain reports from combat injured service members. I mean, their worst pain intensities. These injuries are devastating. These are injuries that I've never seen in civilian trauma. Their pain reports are lower than what you would expect, and they're a male population predominantly. They're service members. They're most likely stoic. And that's a problem if they're not being very forthcoming in the amount of pain, because you know that people who bear pain get central sensitization, a condition in the spinal cord that perpetuates their pain. So we're rather concerned about that. And these are the neuropathic pain symptoms. Again, almost all these patients had neuropathic pain, nerve injury pain, but their scores are way lower. There's a scale of 0 to 10, so their scores were under 3 for neuropathic pain symptoms. These would be symptoms that you would see in diabetic neuropathy patients that would be much higher. Now, they are on multimodal analgesia, many of them, which is good, and that may be why they're actually getting such good outcomes, but still concerning. And then we administered the Treatment and Outcomes and Pain Survey, the TOPS, which is 14 subscales, and Dr. Carr was one of the developers and originators of the TOPS, which is 14 subscales, and we are just reporting 7. But again, no difference between these subscales. No significant injury level difference. That's the ISS effect, so there's no group effect. There's no time effect, meaning that after 6 months of leaving the hospital, they're all pretty stable. They're all having the same course and pattern, so they're not improving, is what our data overall are telling us over and over again. And if we look at their scores based on the scores that we would see for patients who actually have, from a chronic pain population, their scores are lower than the impairment. They're poorer, they're better than, because the lower score is, the higher score is actually poorer, the lower score is actually better on these subscales that are shown in this graph. So they're actually doing better than our chronic pain population. And they're not at all like our chronic pain population. They're not typical of the kinds of patients that we see who have chronic pain and who are very debilitated and not able to engage themselves in life activities. Our combat injured soldiers are rather resilient. And we also wanted to look at PTSD symptoms, and the injury severity really had no effect on PTSD symptoms way out after the injury. But one of the things that we did find is that the patients with that the overall patient population out of the 347, 46 reported a cutoff of over 28, which would be PTSD, and 14% of them, 48, actually had severe PTSD. So the connection of practice to science. So, I mean, generally we like science to guide the practice, but with the military, the practice often moves so quickly before the science can even catch up. And so I just want to talk to you a little bit about my very foundational science building programs of research in the military, because after we did the RAMPOS, after we got the RAMPOS grant and I started going down to Walter Reed, I started being very inquisitive and wondering, why can't you do this, why can't you do that? And one of the questions I wanted to know is, why can't you collect data on combat injured soldiers at the point of injury in the combat support hospital? And 2 anesthesiology fellows looked at me like I had 4 heads. Like, how could we possibly do research in a combat support hospital when we're in harm's way and it's an austere environment? So I was bound and determined to be able to get real-time pain data in a research study, and I'll show you how we eventually moved back. So the RAMPOS study studied U.S. service members in the United States who were way out from, or at least somewhat out from their combat injury. They had been discharged from the hospital. And then I wanted to really look at, and Colonel Buckemeyer in 2008 went to Lonsdale Regional Medical Center. I said, wow, what an opportunity. Let's get data there. So it's not in the combat support hospital, but that's where they're flown, so they're usually close to their point of injury. And so he was armed with a study that he did there with Christine Rubert, a clinical nurse specialist. And we wanted to collect data on the experiences of soldiers during transport, during the 6-hour transport from Afghanistan and Iraq combat support hospitals to Lonsdale Regional Medical Center. This is the inside of the aircraft. It looks like a hospital, but they're stacked. If they're not critically ill, the ones that are critically ill are in another aircraft that looks like an ICU, that is an ICU. It's a mobile ICU. but these are for combat injured soldiers with limb injuries who are not critically ill, who are stable, and there could be about 40 of them, very few aircraft medics and nurses caring for them. And nobody really ever asked them what their experiences were, but we did. So we developed the POWER survey, which was an abbreviated, we stole items from the brief pain inventory, and it's so great in pain to have generous scholars and colleagues, but Charlie Cleland, who actually developed the brief pain inventory at MD Anderson, we called him and said, you know what, we really want to snitch items for you for the military, go ahead. So we got permission to actually snitch some of the items from the brief pain inventory and put it into a POWER survey. And why do we call it POWER? Well, that's pretty interesting. I was at the American Academy of Pain Medicine presenting these data right after one of our most renowned Australian researchers was just presenting his groundbreaking research. And here I am presenting a survey, a 2-page survey to the audience. And he came up to me afterwards, and I was so nervous that he was in the audience. He came up to me afterwards and he said, I never realized the power of a survey. So we named it the POWER survey. Dr. Bogdock, so he didn't know that he was responsible for us. So what did we find? Again, low pain scores, not what you would expect. They were reporting their experiences, both their average pain and their worst pain. And anything over 5 on a scale of 0 to 10 would be moderate to severe pain. But they were reporting that they were anxious and they were distressed and they were worried. And we did actually a content analysis of their responses. We asked them, what were you concerned about most and what were you concerned about least? We got a lot of qualitative data, short data. So qualitative researchers like patients to talk. They like to get very in-depth responses. Well, these service members who were injured were getting reunited with their family, figuring out how they were going to get back to the U.S., were under enormous stress. So this wasn't the time for an interview at Lonsdale Regional Medical Center. So we actually did get as much data as we could, and we analyzed them qualitatively and found out that these were the issues they had: fears, communication, concerns, confidence, and trust. And they really wanted to know what was going to happen to them. What were they going to do without a leg or both legs? But these were the data that brought me to tears. I mean, it really is very moving data. But this is just an example of some of the excerpts from the concerns that were expressed. And if this doesn't get at your heart, I was worried about my 2 friends who died and how their wives and kids would do without them. They are both having babies in June. And how my crew was doing. 2 died and 1 is in ICU. So they had major injuries and they were worrying about their units and their fellow troops. And one of the things that we knew is that when they're in the combat support hospital, they really want to be reunited when they're injured with members of their troops. So they try to arrange that. So these data were published in Pain Medicine, and they were data with 110 service members. And these data really informed the transport, the medics and the Army and service member nurses, healthcare professionals, and CRNAs in actually understanding the transport experience. The little things that nobody ever expected, that if they were on the top bed, they were afraid they were going to fall on the bottom because the plane actually flies low and hits a lot of turbulence. And if they were on the bottom, they were afraid that the top person would fall on them. Some of them reported that they had to go to the bathroom, and it was very distressing because they didn't want to go when they were on the plane. So I mean, just a lot of things that no one really looked at. Now, in 2009, Dr. Colonel Buckenmeyer Tripp, who will be coming here, so you really should make sure he's a wonderful speaker and such an incredible leader in the military. He actually went to Afghanistan to start a pain service and went to Camp Bastion, which is the largest British military installation. So here was our chance to get real-time data. So we moving back now, and now we're in the combat support hospital. And I said, you can't miss this. So we quickly put together the Power Survey and another survey to survey healthcare professionals about their experience with an acute pain service, because they had not had one. The British Army had not had a pain service in a combat support hospital, and I said, we're going to get data. So it was really easy to get approval to do this study. And then when he came back with all the data just really quickly, we didn't have IRB approval. We had QI approval for the Army. And I wanted the data, and at Penn I have to have a data use and sharing agreement and an IRB approval. And Walter Reed at the time Army Medical Center said, we're not approving this study. This study is was done with the British Army on their terms. So I had to have approval, or I couldn't analyze the data. So I emailed the colonel in the British Army who was working with us, and we were dialing back. And I said, I need approval from for you to have this data. I need an agreement. And he writes back and he says, I'm the colonel of the British Army in charge, and I gave you permission. You can have the data. And that was easy. So this was a study of 71 combat injured soldiers, both U.S. and British, and it actually is not perfect. And Dan always helps ground me in the fact that our no data better than imperfect data, and I'm coming to learn that imperfect data is much better than no data at all. But when TRIP could actually get to these patients to deliver an intervention because of being in an austere environment and the volume that sometimes comes in, and then to get their pain scores and to evaluate them, or to have somebody else actually collect those pain scores, because it would have been a bias if he collected them. He was the one delivering the intervention. So getting somebody to collect the data and getting organized to do the intervention, we just couldn't do them at the same time. He just couldn't do them at the same time at each point of contact with the injured service member. So they were initially, before any intervention was done, assessed. They were assessed 4 to 6 hours, which was as close as we could get. And then some of them were sick, did require care, did have long anesthesia times, but usually most of them were out within 24 hours. They were assessed prior to transport. And quite strikingly, when we looked at the data, the perception of pain relief and the pain intensity, the mean pain intensity, and these are standard deviations bars, the mean pain intensity was statistically significantly different over time. It dropped to 2.5 prior to evacuation. That was really good. And then the perception of pain relief, which on a scale of 0 to 100, with 0 being no relief and 100 being complete relief, really rose, and that was statistically significant. So we were pretty pleased, and these data were published again in Pain Medicine. But then we had the military perception data to get, and this information was really vital for the British Army to have, to see what were the perceptions of the healthcare providers about his presence and the presence of an acute pain service. And so we developed this questionnaire. We vetted it through the British Army. We did content validation on the items in a matter of 2 weeks. And someone, Captain Ellie, I can never, Chisholm, collected the data so that TRIP wasn't involved at all as a bias, and she was part of the health professional group at Camp Bastion. So these are the items that we were hoping everybody would strongly agree on. And what was most concerning was this one. We were hoping that healthcare professionals, or TRIP was hoping, they would not perceive that patients managed by acute pain service would not be able to be transported more quickly. And they were concerned that patients weren't getting out if they had APS interventions. So that was somewhat of a problem. And then these questions, we wanted them to strongly disagree or disagree. And there were some concerning responses. One is about the surgical team should determine what analgesic technique should be used. So there were physicians traumatologists, as well as emergency medicine, as well as a general medicine physician on base. And you can see that over 50% actually were either undecided or really agreed with that statement that that pain should be managed by the surgical team. So they had some work to do, but these data really helped them try and change attitudes. So then my area of interest is with ketamine, and we did a study in 2009. The practice had already occurred, and then we tried to get some data on a cohort of 19 injured service members that actually had to be hospitalized and were hospitalized for their ketamine therapy. So their therapy itself was quite intensive because this was the first time they had launched ketamine. Now, many of you know ketamine is an NMDA receptor antagonist, and some of you might not know that, but it actually antagonizes the receptors in the dorsal horn of the spinal cord that are responsible for causing chaos in producing or sustaining chronic pain states or persistent pain states. And so we wanted to look at in this cohort whether those with peripherally mediated pain, mangled limb or residual limb pain from an amputation did better than those patients who had phantom pain who had had amputation. And what we found was that the patients that had peripherally mediated pain actually had a better response to ketamine. And this was just a small study, but we did really sophisticated mixed effects modeling statistics, which actually gave us very meaningful patterns of how these patients did. So actually, when the manuscript went out for review, the reviewers had trouble understanding mixed effects models, so we had to redo our legends to actually explain it better to readers. But overall, you can see that overall they did well with ketamine, but those who had more severe, worse pain got the best response, as you would expect. And why did we want to show that? Because we want to be selective about who gets ketamine. We want the people who really need it with the people with high pain intensities to get ketamine. And as I said, we showed that patients with phantom limb pain, without phantom limb pain, had a better response than those with phantom pain. So we were always very committed, Tripp and I and Matt Gallagher and Colonel Kevin Galloway. We were always really committed to trying to get these data out and trying to inform. And so in 2011, we did a symposium, War on Pain, at the American Society for Pain Management Nursing. And at this symposium, we really gave tribute to Army Specialist David Alex Knapp. He was injured in Iraq, bilateral amputee, rehabilitated himself, was only at Walter Reed for 2 months, which is unheard of for a bilateral amputee. Went home, was very active, actually golfing and doing ice hockey. And he was just about to get a new home built by Home for Our Troops when he died of a fatal heart attack playing ice hockey. So sad. The distribution of blood and circulation with bilateral amputees is severely compromised. It taxes the heart. So this is not unheard of. It's uncommon, but it does happen in bilateral amputees. And so we honored his mother and his brother. So sad. Here I was giving the award. There wasn't a dry eye in the audience. And as a result of that, we produced a supplement to American Nurse Today, not a very high-impact nursing journal, but hits many, many, many nurses. We got so much positive feedback and appreciation from military and veteran nurses because we actually wrote these articles for them, for care of veterans with pain and care of service members. And you can see Dr. Buckenmeyer, Dr. Gallagher, and Kevin Alloway, who's a nurse and who was the chief nurse for the Office of the Army Surgeon General. And then in 2009, those three actually led a task force that was commissioned by the Lieutenant General, the Army Surgeon General. And that task force worked on, there was a 22-member task force, worked on trying to come up with recommendations to improve pain management. They came up with 109. But our studies informed our prior studies in the Combat Support Hospital in the Landstuhl, Germany, and our Rampos study actually informed the recommendations. And they also talked to clinicians in both VA and military healthcare settings. And they found that the numeric rating scale and the way we measure pain was grossly inadequate. So they started and developed an instrument that would use word descriptors to ground the intensity of pain. And here's where I came in. I helped with the validation and designing the study that would actually test this scale. And the British had already said, we've been operating in nursing that pain is whatever the experiencing person says it is, so believe it. And the British had already been very proactive by actually putting a statement in their literature for military, is pain really what the person says it is? Because they were noticing the same thing about underestimation of pain. So this would help prevent that. It also provided screening questions. And so we did this really neat study where we validated the tool, and a subset of randomly selected military service members who were hospitalized, actually, there was a Velcro board, actually took the word descriptors and placed them where they were supposed to be. And then we measured how their percent agreement if they got it correct. And these are the data for those placements. And we knew that there'd be some discrepancy with agreement, especially around 5, 6, and 7 with the word descriptors. But it was pretty close. And we did a percent agreement assessment with an intra-class correlation coefficient, allowing for them to have one deviation. And with that one deviation deviating, there was an overwhelming majority in almost every category that were just one off. The interclass correlation was above 0.85, which is acceptable. So we used the wrong faces. We used faces from the IASP that said we could use faces for research for this scale. And then we were not allowed to use those faces. They would not give us permission for the scale. So we had to redesign new faces, do focus groups. These were some graphics that we first came up with, and when there were all kinds of problems. What if they didn't have limbs? Does this mean that they have a headache? And these focus groups, patients uncovered all of these things. These were too scary for women reported. They just look really scary. So the winner was these faces, and these are now the faces that are on the scale. So this DVPRS really adds value to the military pain assessment, and it's being used everywhere, just with this one validation study. And I'm a reviewer for the Congressional Defense and Medical Research Program, and grants are coming to us using the DVPRS as a pain outcome, so it's very exciting. So I just wanted to talk briefly about my work with evidence-based practice and monitoring patients. These are my colleagues, Carla Junquist and Joyce Willens, and both Dr. Junquist and Dr. Willens are active members of the American Society of Pain Management Nursing. And we did a practice analysis looking at nurses monitoring practices in hospitals, because we were very concerned that patients getting opioid analgesics weren't monitored. So we found that they weren't being monitored, and so we developed a 37-page evidence-based practice guideline document. Took us over a year and a half to do. Most of these nurses who were authors were master's prepared nurses. This is the first time they ever graded evidence and ever participated in an evidence-based guideline process. And then we resurveyed nurses and found that practice wasn't any better. But, you know, that wasn't the only thing. At the time, that the Centers for Medicare and Medicaid were also concerned about patient-controlled analgesia and whether patients were monitored. So our guidelines actually informed a panel, and our panel actually had the luxury with CMS support to do a survey, a random survey of hospitals. And these are a lot of data, and just to highlight, We wanted to see that hospitals were actually monitoring patients in the first 24 hours getting IV PCA, 2.5 hours, and you can see that only about 8% of hospitals were doing that. And look at 4.5. Some of these hospitals were doing every 6 hours on patients just started on opioid analgesics. And these were the monitoring, optimal combination of monitoring practices that we wanted. So this is the ideal. Some of them did do these other parameters, but this one was the ideal and they didn't meet the muster. And so we're very committed to sharing with executive nurse leaders and also with practice leaders about the evidence-based monitoring. And so this is a review that's in press now that some of our members of our team did, and we're hoping to get that out. So lastly, I just want to talk about my Quality Improvement National Initiative and having the opportunity to work with the American Pain Society Task Force in revising the American Pain Society Pain Questionnaire. So in 1995, there was a questionnaire to measure quality that was published in I think it was Archives of Internal Medicine. And it was so cumbersome to use, you couldn't get a score, and it wasn't widely used. So we put together a task force, and Deb Gordon led that task force. Dr. Gordon is at University of Washington now. And she developed some items and sent them out, and we vetted them, and they were tested. And I did the analysis with Dr. John Farah, and we actually found that these items on these instruments were responsible for 5 different conceptual domains or measurement domains of whether or not quality care was delivered. And then we decided that 300 wasn't enough, so now I lead a study actually with 1,000 patients in our database. I'm getting ready to prepare that manuscript in January, where we actually found a different factor structure. We found different concepts. So we're going to be changing the subscales for this instrument, and this is a factor analysis is done to actually help group items. These are examples of all the 18 items on the survey that are given to patients and where they fall into the different subscales. And so it ended up for, and these data come from 7 hospitals, much more representative, that we actually have 4 domains that you saw in that. We also showed that patients with, who were medical patients versus surgical patients had poorer outcomes. Medical patients had higher percentage of time spent in pain than surgical patients. Surgical patients were probably treated more aggressively. And they also had poorer pain relief compared to surgical patients. So that was quite interesting. This instrument actually guided the Pain Out registry, which is from the European Commission. It's a registry of over 40, now maybe even 50 international hospitals that contribute data. And our APS-POQ is the patient-reported outcome measure that they use for Pain Out. And here we are presenting at the American Pain Society in 2011, the Pain Out folks and Deb Gordon and myself and one of our other physicians. And the interesting thing is that the APS-POQ is actually an HCAHPS approved instrument. So you can give it to inpatients. You're not supposed to survey inpatients at all around satisfaction or any outcomes that the HCAHPS asks. You can get fined. There was a law in 2009, but ours is HCAHPS approved. And our APS-POQ I took to Botswana. It's translated in Setswana. And I know on one of the slides you saw that the APS-POQ is translated into 10 different languages. So it's on the website, the American Pain Society website, if you want to access it and you have permission to use it. So we went to Botswana, we redesigned care there. They give new meaning to floor beds. I don't use that word anymore because their beds are literally on the floor when they have in the hallway. So when they have a high volume, they're literally on the floor. So We were trying to get the throughput better with the clinical pathway with the APS-POQ, and we did show in this limited study that we could decrease the length of hospitalization and improve pain management. And lastly, I just want to say that I've been very committed to pain education. This was a national program, Inroads for Pain Management, that I chaired. It was a program that was an internet site and web-based educational program resource. There were slide resources for faculty, for nurses to take. There were webinars, regional on-site education, symposium and national meetings, publications, and educational research. And this is an example of our educational research. A clinical trial was done. There were 547 nurses, so Inroads educated thousands and thousands of nurses all over the country. But during a period of time, there were 547 nurses who took the Inroads program. 93 of them were randomly selected, and then another randomly selected cohort of nurses served as the control. And just to briefly give you just a snippet, the nurses who took the course actually answered correctly, a higher percentage of them, in every case study analysis example. The top one, the nurse participants, the second one is the right answer to that scenario. So we were able to do a clinical trial, which is pretty unusual, with educational research demonstrating the effectiveness of this program. And we are, as Harvard is an NIH Pain Consortium Center of Excellence in Pain Education. We're all waiting to hear tomorrow whether or not we got our new grants that we renewed, and Harvard is partner with Penn and Pitt. We actually put our proposals in together, so I'm really excited, and I hope that we get to all work together. So thank you very much, and I'll take any questions. 1 minute over, Dan. Dan was afraid I wasn't going to get through all my slides.
If I understood it correctly, with the initial severity, was there a control for whatever pain management they had prior to that? So not everybody got the regional anesthesia.
Oh, so part of the study aim, so I showed you the ISS, but the main study aim was to see if early regional anesthesia made a difference. So yes, a cohort of patients received regional anesthesia within days, within 1 week, within 2 weeks, and within 2 months. And we're compartmentalizing them that way to see how that affects the outcomes. No, not all of them, just a cohort, right? That intervention is only dependent if someone is skilled in the combat support hospital to do it. And Tripp is just amazing. He can put a regional anesthetic catheter in and you can blink and it's in. So yeah, it's, so we'll have that information as to whether that works, and God forbid if we have another conflict, then it will really be the science to support pain-trained anesthesiologists. So in the mid 2000 era, there were only 10% of military anesthesiologists who had actually gone through pain fellowship programs.
So I'm thinking it's Workin's work around phantom limb pain.
Mm-hmm. Yeah.
Predictor of long-term chronic pain, but you looked at both the cohort and what you were saying there was no difference. It didn't matter.
No. So our data is on injury severity. So I showed you the data that their injury severity score. So if they had a really bad injury versus if they had a mild injury, it didn't make a difference panning out 6 months after they left the hospital. They were all doing the same. Okay? So we don't have the data analyzed for whether they got regional anesthesia or whether they got, but good question, and thanks for clarifying whether they didn't.
Okay,
so
thanks.
That's the whole purpose of the RAMPO study, but we're actually analyzing that now. Yeah, we'll get it out soon, hopefully. Any other? Okay. Oh, go ahead.
Question. I think most of the people in the room have a sense of the vast scope of what you presented. It's very remarkable for one person. But as science progresses and time progresses, each of these areas becomes progressively more differentiated and complex advice would you give to someone who, whether it was from a nursing background or not, was starting out in the pain area?
Yeah. So my research is scattered because I also have a position in a hospital where I have to help other people do research. So I have to support their research agendas. So, I have to go along sometimes with some of the studies I do for the ride. I think that to carve out programs of research, and I say programs plural because you don't have to have just one, but I think if I carved out my programs of research, it's my chemotherapy-induced peripheral neuropathy and my military research programs. And I've been pretty focused, and the advice I would give is to try to use and study the same outcomes or study different populations in different settings as you build your programs of research. That's how you build your science. I think that the advice I would give is to work with great teams and have great mentors. I think that's really the ingredient to no one gets anything accomplished themselves. And I wish I had time to mention all the people, but you saw all the authors on the studies, and we had just incredible team science is just really a program of research that you can build with a team, and doing team science is the biggest or the most important recommendation I would give to people starting out. Get a team, get a mentor, work with people who work with people you can count on. Like Tripp and I mean, we have a style working together to get these manuscripts out, and not everybody is on the same page with us, but you at least have to have one or two people on your team.
I just wanted to say the sickle cell article, I remember reading it, I remember how impressed I was, I remember how it informed my work at MPH, like yes, we need to adopt cancer pain management approaches to people with chronic severe pain. So even for me as a clinician, that publication was seminal in terms of
Thank you.
thinking.
Yeah, it was really a great study to do. Not all the patients, thought it was a great intervention, but
I want to echo Judy's sentiments. I got to stand next to Dr. Brookoff when he presented your poster at the American Pain Society in New Orleans a long time ago. I was in graduate school.
great. Well, that's great, and
That's how I remember that article, and that's how I have read everything that you've written.
Thank you.
Get to figure out, you talk about mentors, sometimes you have these informal mentors. You notice the people who do seminal work, and you pay attention when they speak, and that's a form of mentorship, too.
Or when they write.
And Judy being one of my long-term, someone who I admire, but I was sitting on a panel at a national meeting, and participant asked a question, and the guy sitting next to me, well, I'm going to cite the Brookoff study. And I said, wait a minute, I nudged him. It's the Brookoff of Polomano. It's the Brookoff study.
You may not be an answer to this, but you have a patient population that we still know has underlying risk for PTSD. And I think that's an area of pain recognition that is ignored in most of the populations, not just I say that with your children.
Sure. PTSD, the question was about PTSD being a really significant, absolutely. And I wish I had a barometer for it. It's very, very difficult in a military population. Once they get to be veterans, it seems to be expressed more because there's a tension and they're not in the military anymore. But it's very hard, and I think we're going to stop here. That's okay? Is that okay? So it's very hard, because I don't want to be taped. It's very hard to actually figure out who has PTSD and who doesn't with these screens when they're still at Walter Reed National Military Medical Center. And and I only work with the combat injured, major limb injury patients, but there are other people who do report their PTSD and haven't had physical injuries, but have those silent injuries. But you know, I mean, I'm pretty good at interviewing. I'm pretty good at screening, and my colleague has a friend who was deployed 3 different times in the National Guard, and I had heard so much about him for years and years. We finally met, came to my house for dinner, and I talked to him. He was having pain, and I was screening him and asking him all these questions. No, I don't have depression, I don't have PTSD. Committed suicide 2 weeks after. So it's just, you know, if they don't disclose, it's really, really hard. And I think in a civilian population, it's just not as, people just aren't as skilled in the civilian population to really handle it. I mean, you really have to be specialized in civilian trauma to, you know, be looking out and dealing with PTSD. But most of the military know how to screen, they know how to care for these patients.
I think this should go on the record. Thank you very much. Your work is inspiring.
Oh, thank you.
It really makes me think that you went with your instincts and you did the hard work. And it's
Well,
very impressive.
No,
Thank you.
I, as I said, I had great teams and great mentors, and thank you so much. Okay, well, I hope you get home safely. Thank you. You're a great group.